Jerusalem Tilahun. I'm a psychiatry resident over at Western Psych in the US in a city called Pittsburgh. Um, I am in my third year of psychiatry training, so the things that we'll discuss today is kind of a culmination of things I've learned in my training, things that I've researched in preparation for this talk. And I'm excited to share it with you all, and I'm excited about the work that CareEpilepsy is doing, and I appreciate being able to be here and talk about this topic of psychiatric and behavioral comorbidities. Let me share my screen really quickly and then can get started. Can everyone see this okay?
Yes, we can see it. We can see it, Dr. Jerusalem.
Okay, great. All right, so before we get started, I do want to give a warning that some of the things that we're going to talk about are pretty sensitive related to mental health. I will be talking a little bit about discussions of suicide specifically, and so if that's something that feels too heavy for you in this moment, feel free to step away when we get to that part of the talk. I always want to lead with that. So let's start with a little bit of background. Epilepsy, we know, is primarily a disease that affects the brain by causing seizures. And it's a disease with many comorbidities. So people are at higher risk of having cardiovascular disease, issues with other brain disorders, lung disorders, things like that. But today we're going to be talking primarily about the psychiatric disorders that are associated with epilepsy and that people with epilepsy have at higher rates. And I want to start our discussion by talking a little bit about why it's important to talk about psychiatric comorbidities in epilepsy in the first place, and why it's important to look out for these disorders in people with epilepsy. Main reason why it's so important to talk about is because it's very common in people who have epilepsy. 1 in 3 people with epilepsy have a psychiatric diagnosis at one point in their life. And people with epilepsy have a 2 to 5 times higher risk of having a psychiatric disorder compared to the general population. So those are really big numbers. And these psychiatric comorbidities are also associated with decreased quality of life, treatment resistance, and increased mortality. So these are really important things to make sure that we're treating early and catching early, so that it doesn't lead to things like decreased quality of life. I mean, you can imagine it's already, can be difficult to live with epilepsy alone, and having to deal with epilepsy and depression, or epilepsy and anxiety, and things like psychosis can be really difficult. And make it even more difficult for people. In terms of treatment resistance, people with both epilepsy and psychiatric diagnoses have a more difficult times in treatment, because you can imagine if someone with depression, for example, if you're severely depressed, it can be very difficult to find the motivation to do things like take medications that will prevent seizures in the future. And epilepsy also causes some changes in the brain that make it a little bit more difficult to treat psychiatric disorders when they come up. And then there's also an increased mortality rate in people with both psychiatric disorders and epilepsy. So it's really, really important to treat these things early. I want to talk a little bit about why psychiatric disorders are so common in epilepsy. Up to 33% of people with epilepsy, we talked about, have some type of psychiatric disorder. And so why is that? Why is it so common? The first thing is that changes in the brain due to damage from untreated seizures can lead to psychiatric disorders. So literally physical changes in the brain. The second thing is stigma. So stigma can contribute to long-term discrimination, feelings of isolation, shame that can contribute to having things like depression and anxiety. So social isolation, same thing. A lot of times when people have especially really severe epilepsy and have a lot of seizures, the seizures can be very unpredictable, and it makes it you can imagine like someone start to worry about, when is the next seizure going to come? Is it going to be when I'm out with friends? Is it going to be when I'm out at work? And that can make people become more isolated, and it's really important to kind of break that cycle. But that feeling of self-isolating because of worries about when seizures will come can contribute to things like depression and anxiety too. And then the last thing that I wanted to mention of why psychiatric disorders are so common in people with epilepsy is epilepsy medications. And so epilepsy medications are really important, and this is not to say don't take them, but they can be associated with, some of them can be associated with changes in mood, becoming a little bit more irritable, having depression. And so it's really important to talk to the person prescribing your epilepsy medications to make sure that you're on a regimen, a medication that's right for you, and not medications that are causing changes in mood. Yeah. So let's talk a little bit about what these psychiatric comorbidities are. When I talk about psychiatric comorbidities and epilepsy, these are the disorders that I'm talking about. So depression, anxiety, psychosis, cognitive impairment or intellectual disability, delirium, bipolar disorder, and then suicide. All of these disorders and conditions are seen at higher rates in people with epilepsy than in the general public. Now, that's not to say that everyone with epilepsy will have one of these disorders in their lifetime. That's not true, but you're at higher risk if with a diagnosis of epilepsy. So I also want to point out that we'll be discussing some of the symptoms of each of these disorders in a little bit more detail, but what we're going to be talking about are not diagnostic criteria. So I wouldn't use that information, the information that we talk about here, to diagnose. If you're worried that you have some of the symptoms listed in this talk, then I would talk to your doctor a little bit more to try to get at a diagnosis. Let's start by talking about depression. Depression is the most common psychiatric disorder in people with epilepsy. So a lot of times when I see people in clinic, there's a lot of confusion between like, what is depression and what is, how is it different from sadness, right? So, if we're noticing that people are experiencing sadness, low mood for a few days at a time, they're obviously going to need support, but not necessarily treatment for depression. When I talk about depression, I mean you're experiencing at least 2 weeks of the following things. So feeling really down, feeling really sad, decreased liveliness and motivation. A lot of times people have a hard time even just getting out of bed in the morning for multiple weeks when they're in a depressive episode. They'll sometimes even start physically slowing down. So people are moving a lot slower than they used to. They'll start to have and talk about a lot of feelings of guilt. So start to notice or look out for people saying things like, I'm such a burden on my family. And then suicidal thoughts can be pretty common as well in people who have more severe depression. So in those cases, you'll notice people saying things like, I can't keep living like this. My family would be better off without me. Or even things like straight out, like I should just die. Okay, so really important things to look out for. And we'll talk about addressing, suicidal thoughts a little bit later in this talk, but it's something that I wanted to bring up because it's really important and not talked about enough. So these symptoms can be really severe. So we want to talk about what can we do as people trying to support folks with epilepsy um, who are also experiencing depression. So we circled here support from family is very important. So being there for your loved one is going to be a huge thing. With people with depression, their minds are already telling them like they're worthless, no one cares about them, like that's what their mind is saying to them all the time, right? So it's important to show them that they're not alone and that there's people who want to help them. Okay. Another important thing is something that we call behavioral activation. So this is basically um, getting people up out of bed and getting them into a routine. A lot of times people with depression, it's the hardest thing to get out of bed. It seems like an impossible thing to do. Um, and so getting people up, motivating them to get up and have a routine, get outside is going to be really important, even though they don't feel like doing it. But research has shown that actually doing that, even if you don't want to, is helpful for mood symptoms down the line. Okay. Other things that are important are going to be medications. So, and I know like in terms of access to medications that could vary, but if you have access to medications, it could be helpful to get treatment for depression with an antidepressant and also make sure that you have seizure control, because a lot of times with depression in people with epilepsy, the depression is caused by having so many seizures. So controlling the seizures can help manage the depression too. And therapy can also be really helpful if we have access to it. So next I want to talk about anxiety. When I mention anxiety, it can come up pretty frequently in epilepsy. A lot of times when people have had seizures in the past, like we talked about, they worry about when the next seizure will come. And this worry varies in how intense it is and how much of your day it takes up and how much it can affect your daily routine. If the worry becomes really excessive and people are worrying about more than only seizures, then we start to worry about anxiety and things that other things that can come up are panic attacks. So panic attacks are going to be episodes where you're noticing your heart racing, having a hard time breathing, sweating, feeling like something really, really bad is going to happen. And in cases like that, your body's in a very high energy state, right? And so the goal in terms of what we do for people is going to be to kind of slow the body down, like slow the body down, stop the mind from racing. And there are a couple of different ways that we can do that. Again, in this case of anxiety and a lot of the things that we'll talk about, disorders that we'll talk about, therapy and medications are going to be important, but I also want to touch on things that we can do ourselves to help when we're feeling this way. So with that said, grounding techniques are a great way to help when anxiety is getting really intense in the moment and you don't have access to a therapist right away or medications right away. So these are things that you can do just with all you need is your body to do these things. And so the first one is box breathing, which we'll do an example together in a second. The other technique that I wanted to talk about is we call it the 5-4-3-2-1 method. And basically the point of this is to get people out of the rush in their mind and into like focusing more on the environment around them in order to decrease that anxiety. So this is trying to get someone to identify 5 things that they can see. So literally just in your environment, like I see a lamp here, I see like some colored pencils here in my office. So 5 things. 4 things you can feel, with your hands, and 3 things you can hear, 2 things you can smell, and 1 thing you can taste. So it's a very simple thing, but it's something that can get you focused on anything other than what's racing in your head. Okay. And then the other thing is box breathing, which is basically a breathing technique to, again, help slow the body down a little bit. And I wanted to work on that together with you guys just to give you an example of how you would do this. So basically, you're imagining a box and taking really slow breaths in and out as you're imagining tracing this box. So you would take a deep breath in and count for 4. So 1, 2, 3, 4. It's a really slow breath. And then you hold for 4. 1, 2, 3, 4. Hold your breath for that 4 seconds and then breathe out. 1, 2, 3, 4. And then hold again. Your breath for 4 counts. And you're doing it as you're tracing this box in your mind. Again, it's a really simple thing, but it's something that really slows down your breath and that eventually slows down your mind, and can help calm people down in the moment when they don't have access to anything else to calm them down. Okay. So the next disorder that I want to talk about is psychosis. So psychosis is a psychological state, and we define it by basically losing contact with reality. A lot of times in people with epilepsy, psychosis comes up, it can come up directly after a seizure. So in that post-seizure period, people might have psychotic episodes. It can come up during a seizure, and it can come up even in between seizures as well. And so when I talk about loss of contact with reality, what I mean is there's a few different symptoms to look out for. So seeing or hearing things that are not actually there. So these would be hallucinations. So people can have like say that they're hearing like a loved one who's not actually in the room, or hearing someone tell them to do something who's not actually there. Sometimes you'll even see people talking to someone and there's no one else in the room talking to them. So that comes up. And other symptoms to look out for is speaking in ways that don't make sense. So people are saying words, but the way the words are connected is not making sense to you. So that can be that we call that disorganized thought process, and that can be a sign of psychosis. Being overly suspicious of other people, and thinking that they have bad intentions when they don't, to the point of in a really intense way, like to the point of paranoia, would be one of the things that help cue us into whether someone's going through a psychotic episode. And then also having beliefs that are not based in reality. So we call these delusions. A really common one that I see is people saying that they're being like chased by police when they have that's not actually happening, and they have no legal history or anything like that, and they're saying that the police are after them. So in cases like this, typically people are going to need to be in the hospital, especially when it gets really severe. So getting someone to the nearest hospital is going to be really important to make sure that they get on the right medications, have the right care, and these episodes don't recur or come back. But as family members, it's really difficult to deal with situations like this, because it's you and the other person are not in the same world at that point, right? They're in a completely different world. And how do you bring them back from that, right? It's really difficult. One of the things that I've found helpful is focusing on validating how they're feeling, but not validating the belief that they're having. So if someone is saying that they're being chased by police, for example, when that's not true, you say, that's really scary, but you're safe here, right? So validating how they're feeling. You're not saying like, oh, the police are actually chasing you, let's like get you to like somewhere else, somewhere safe, right? You're not saying that you're not acknowledging that they actually believe that thing, but you're telling them I know how you feel, and this is a safe place for you. What usually doesn't work, but people will sometimes do, is saying like, oh, that's not true. Um, a lot of times the person experiencing the psychosis won't believe that. Um, and it will just make them feel a lot more isolated, even though it's true that that's not what they're experiencing. It'll kind of just push them away a little bit. Um, and then the last thing that I wanted to touch on with regards to psychosis and helping people going through psychosis is a lot of times people have a hard time remembering to take care of their basic needs when they're going through a psychotic episode. So reminding them to eat something, reminding them to drink water or shower, small things like that can also be very helpful. So, one of the other comorbidities that I wanted to touch on is cognitive impairment and intellectual disability. So, epilepsy also occurs commonly in people with intellectual disability or people with frequent in people with frequent seizures. It can also lead to cognitive impairment later in life. So when epilepsy occurs in people with intellectual disability, it's typically diagnosed at a young age, and the kids will have some type of disability in learning or social skills. And the severity of their epilepsy is going to be proportional to the severity of the intellectual disability or cognitive impairment. So the more severe the intellectual disability, the more severe the epilepsy is going to be. So with intellectual disability, the main thing to note is having family support to take care of the child is going to be very important. The person is going to have a lot of needs, and so having support from multiple people and not just putting it on, a couple of family members like the parents, is very helpful for the child and for the family that's trying to support them. And if you have access to other support services, that can be helpful too. Delirium is also something that can come up in people with epilepsy. Usually, delirium will happen right after a seizure, is when I've seen it most often. So this is a non-permanent state of confusion. So it's not a permanent thing. But it's the state of feeling really confused, especially after a seizure. Other medical conditions can also cause delirium, but I want to talk about it specifically with regards to seizures and the post-seizure state. So things that would cue us into like thinking that delirium is what's going on is the person just seems very confused, like to the point where sometimes they don't remember who they are, they don't remember where they are, they don't remember what day it is, what year it is. They are just feeling very confused, have memory changes. It's going to be difficult for them to pay attention to a conversation that you're having with them, so they're very inattentive in that time. They'll have altered level of consciousness, meaning that they can be very drowsy, very sleepy. And then, like I said, this can occur during a seizure or after a seizure. And the amount of time that someone spends in delirium after a seizure varies a lot. So it could be a couple of hours to a couple of days. So it's really variable. Important things to keep in mind with delirium and helping someone who is a family member or a friend, if you notice that they're going through an episode of delirium, is you want to reorient them. And what I mean by that is like we said, they're going through a lot of confusion. And so making sure to always to frequently be telling them like who they are, what their name is, what the date is, where they are, and then keep familiar people close by. And if familiar people can't be close by, having pictures of people that they know up will be important in getting them feeling less confused over the long term. Other important thing is going to be getting them to have a good sleep schedule, making sure that they're around sources of light during the day and it's dark at night so that they can get their circadian rhythm, their sleep cycles, and keep those intact. If they wear hearing aids or glasses, it's going to be important to make sure that they have access to those. You can imagine if someone wears hearing aids and doesn't have them, it's going to be very difficult to know what people are saying. It'll make you more confused. And then with delirium, if if you're pretty sure that the cause is someone just had a seizure and they're feeling confused, that's may not necessarily need hospitalization if the person has had multiple seizures in the past. But if there's concern that there might be other things causing the delirium, it's going to be important to go to the hospital to make sure that there is no other medical causes of that state. Okay, so mania and bipolar disorder are also some disorders, states that can happen in people with epilepsy. Not as common as some of the other ones that we've discussed, but still more common than in the general public. So when I say mania, I mean a state of abnormally elevated mood and energy. When I say abnormally elevated mood, I mean the person is feeling really happy, like they're on top of the world, or very irritable. So like they anger very easily. And then bipolar disorder would be when people cycle through episodes of mania and episodes of depression. So they kind of go back and forth between those states. So when we're trying to figure out whether whether someone's going through an episode of mania, the things that we're looking for is they're not going to be sleeping for multiple days at a time. Like if someone's not sleeping for 5, 6 days at a time, and they're not worried about it, they're like, I don't even need this sleep. I feel great. That's something that's gonna cue us to maybe there's some mania going on. Their energy is going to be really high. They're going to want to take on a lot of projects. They're going to feel like they're on top of the world. They sometimes will spend a lot of money that they don't have and get into a lot of debt, trying to contribute to different like projects and ideas that they have. They'll experience some grandiosity. When I say grandiosity, this word right here, this is basically pointing to people having a very high sense of self to the point where it's abnormal. So you feel so highly of yourself that you want to run for president, even though you've never thought about being in politics. Or I'll see people also say like they think that they're God or they were called by God to come and like save the universe and things like that. So very abnormal thoughts. The other thing is that these people will be talking really fast, much more than usual, and in ways that don't really make sense. So it'll be really hard to follow them. They'll be switching topic to topic to topic, and it's difficult to keep track of what they're saying. So in situations like this, similar to when we were talking about psychosis, it's important to consider going to the hospital. Medications are going to be really important in managing manic episodes and keeping them shorter. The other things that we can do that are related to like things families can do is mania is going to be one of those like very high energy states, so you want to decrease the stimulation in the room, so making sure they can be around like low light areas, low sound areas, just making sure to decrease how stimulated they are. And then similar to psychosis, helping with basic needs is going to be important. So again, reminding them to eat, to drink water, to shower, things like that. And I want to talk a little bit about suicide because a lot of the disorders that we mentioned increase people's risk of suicide. And even regardless of that, people with epilepsy have a 4 to 5 times higher risk of suicide. And that's even in people with epilepsy who don't have a psychiatric diagnosis. So there's definitely a higher risk in people with epilepsy. So I think it's important to talk about, even though sometimes it can be pretty difficult to talk about. So things that increase suicide risk are going to be past psychiatric hospitalizations. So if you have a history of a psychiatric disorder, you've been in a psychiatric hospital, that can increase risk. Um, if you've ever attempted suicide in the past or tried to attempt suicide in the past, or have family members who have attempted suicide, that can also increase the risk of suicide in the future. Having access to weapons, so things like knives, guns, things like that. Um, Substance use, so using alcohol, using drugs, um, like cocaine, methamphetamine, things like that, can increase risk of suicide. Because you can imagine when people are on drugs, it's you're not thinking very clearly, and if you are having suicidal thoughts, it becomes a lot easier to act on them, because you're not thinking clearly. Your rational mind is not on. And then social isolation can also increase suicide risk. So things that we can do in order to help people who are experiencing suicidal thoughts, the most important thing that a family member can do or that a friend can do is speaking openly about suicide. And if you're worried about it, asking the person about it. A lot of times it's very difficult to talk about and ask about, but speaking openly about suicide and whether someone has a plan or thoughts about a plan for attempting suicide is going to be important. Identifying warning signs. So last time someone had suicidal thoughts, what was going through their mind? What were the triggers is going to be important to know. And then identifying supports. So making sure that there is family or friends around that can support the person. And then if there are mental health professionals around as well to support the person, that can be really helpful as well. And then decreasing access to weapons or means to attempt suicide. What I mean by that is basically taking away things that the person can use to try to end their life. So these will be things like guns, knives, locking up medications that people might use to overdose, making sure that they don't have access to like belts or things that they can use to choke themselves, stuff like that. Okay. And then I want to talk a little bit about behavioral challenges that we can see in people with epilepsy and comorbid psychiatric conditions. And this is particularly aggression or agitation. A lot of things can lead to aggressive behaviors or agitation. There's too many to present on this list, but basically it boils down to a person is not able to communicate that they have a need or they're in distress, and they don't have any other way to talk about it other than lashing out. So when someone is aggressive, obviously we know that they could be physically or verbally aggressive. And so they might be yelling, punching, throwing things, kicking, biting. And so this is a really high energy state, like some of the other disorders that we were talking about. And so it's going to be important to help calm the situation down in a way that maintains your safety and your loved one's safety. So a couple of tips to do that is you want to give the person space. Okay, so at least stay at least 2 arms length away from them. So if you put your arms out from either side, you want to make sure to be that distance away from the person. It'll make the person feel less threatened, and it'll give you space to avoid like sudden physical attacks. Being mindful of your body language is going to be really important, and avoiding ways that you're moving your body in ways that might be considered threatening. So like not crossing your arms, not closing your fists, making sure to have like open body language, and show that you want to listen to them. Using calm voice. A lot of times when people are yelling at us, it's easy to kind of want to yell back, but using a calm voice is going to be really important to, again, bring the energy of the room down. If there are multiple people in the room, we want to make sure that it's like one person talking at a time to avoid kind of adding to the chaos of the room. Um, the hardest part of all this is identifying wants and feelings. Like we said, usually when people get aggressive or agitated, it's because there is some need or some issue that is not being addressed. And it's usually very difficult for the person in the moment who's very aggressive or agitated to tell you why they're feeling that way. So but trying your best to identify what they like want or what they need if they're in pain, things like that is going to be important. When you're trying to figure out what they need, using concise language, simple language, how can I help you? You're upset, what's going on? Naming the emotion can be important. If the person has medication that they're prescribed from a doctor for aggressive behavior, like if it's been a pattern and they have medication, use it. That's going to be really helpful in bringing the person uh, to a lower energy state a lot more quickly. And then do what you need to maintain safety. So make sure that you can have like a, if this is happening in a house, you can have like a designated room where they can go, where there aren't a lot of things that they can like break or things like that. And they can like take some time to cool down in that room. Okay. So having like a safety room, um, having like neighbors or other people like friends, family designated to come and help out when people are struggling with aggressive behaviors. Um, so making sure you're getting all the help you can get. And then if you know still things are not really calming down, very last resort is going to be to call the police or call law enforcement, if you're really worried about like this is very dangerous for you or for the other person. Would be calling law enforcement or getting them to a hospital. Okay. And then it's also going to be important after everything calms down, right, to try to figure out when they're calmer, like what was going on there, what was leading to you feeling so upset, and really try to get a sense when they're calm, about what was going on so that we can figure out what the triggers were and what we can do to help when things are like a lot more chaotic and the aggression is happening actively. Okay. So this piece here, debriefing, is going to be really important. So this is just a summary slide of some of the things that we can do to help people going through mental health crises, who also have epilepsy. We talked about all these things already, but just to summarize, helping out with basic needs, being present for your loved one, using some grounding techniques or de-escalation, safety planning, and then being evaluated by a psychiatrist, a neurologist, or a primary care doctor. If you have access to that, it's going to be the most helpful things that we can help our family members or loved ones do. If you or your loved one are experiencing psychiatric symptoms that are leading to like danger to yourself or to other people, again, it's going to be important to consider going to the hospital. I think I actually might have forgotten to mention, but going back to this slide, all of these kind of tips that we've talked about are part of safety planning. So when I say safety planning, on this slide, I mean all of the things that we've discussed earlier. So I want to open it up to questions and comments. I appreciate your time and you listening, and I look forward to hearing from you all. I'm very curious about your thoughts. Particularly, you know, I work and I'm doing psychiatric residency in the US. And so our mental health system is going to be different from mental health system in Ethiopia. And so if anything felt particularly helpful, or on the other hand, if anything felt like, like this is not really something that I could see myself doing or that we have access to. I'm very curious to know either way, if you have any thoughts on that. So I see some questions in the chat already. Let me stop sharing my screen real quick and can get to some of these questions in the chat. So Ignaz was asking, when someone experiences psychosis as part of their seizure, often called post-ictal or ictal psychosis, is this considered a mental illness or a seizure-related episode? How do we distinguish between psychosis? Oh, that's a great question. So how do we distinguish between psychosis caused by epilepsy and a primary psychiatric disorder? So that's a great question. And that's basically, there are two. Psychosis is not itself a psychiatric diagnosis. It's a syndrome that can point to multiple different diagnoses. Okay, so psychosis can be related to a seizure and epilepsy, in which case it would be a psychosis related to a medical condition related to epilepsy. Or it can be a primary psychiatric disorder, meaning that in addition to epilepsy, the person also has a psychotic disorder, something like schizophrenia, or what we call schizoaffective disorder, for example. The main difference between how you would distinguish between psychosis related to a medical condition and psychosis related to a primary psychiatric disorder is going to be the timing. So if someone is going through psychosis and it's right after a seizure and it lasts like 2 or 3 days, I'm not really going to be concerned about a primary psychiatric disorder, especially if it only ever happens after a seizure. But if someone experiences a seizure and then are doing okay for a couple of days after that, and then you start to kind of notice psychotic symptoms that are then lasting for weeks to months at a time, and it doesn't necessarily go away after the seizure is over, like it lingers for weeks or months after the seizure, then I'd start to be a little bit more concerned about a primary psychiatric disorder. Could you clarify? So the next question is, could you clarify why cognitive impairment is listed under psychiatric or mental health comorbidities? I always thought cognitive issues were more related to physical or neurological conditions. How do we differentiate between cognitive impairment as a mental health issue versus a neurologic one? Also a great question. I wouldn't necessarily. So cognitive impairment is a condition that is treated both psychiatrically and neurologically. So it requires kind of a multidisciplinary approach. Cognitive impairment and intellectual disability can have a lot of neurologic symptoms that require a neurologist to treat. There are also a lot of behavioral symptoms that come up in people with cognitive impairment. So I treat people with dementia and with intellectual disability quite often for things that come up like behavioral disturbances, psychosis, aggression, that are treated primarily, at least in the States, are treated primarily by psychiatrists. So it's multidisciplinary, the treatment for cognitive impairment. That's why I included it. Did that answer your questions, Nat?
Yes, it did. Thank you so much. Thanks.
Yeah. And then Hewitt was asking, what are the treatment options for a child diagnosed with epilepsy with a comorbid conduct disorder? So with conduct disorders, typically therapy-based treatments are going to be more helpful than medication-based treatments. There are medications that can kind of help in the moment with conduct disorders and like getting people a little bit calmer. But therapy has been shown to provide more long-term benefits for conduct disorder. Did that answer your question, Hewitt? I don't know if she's still on. So next question is from Mary. How can you differentiate delirium from an absence seizure? So that's a great question. Delirium is typically going to be, you're going to have more symptoms and more confusion related to delirium compared to an absence seizure. So an absence seizure is kind of like a brief like loss of consciousness moment, but eventually the person comes back to. Delirium is going to be, you're going to have at least a few days of like waxing and waning attention, confusion, things like that. And I wouldn't expect from an absence seizure for it to last that long. So it's mostly the timing, delirium lasting at least a couple of days, and absence seizures lasting maybe like minutes to hours would be the main difference. And then a lot of questions here. I want to be mindful of time. So if you do need to leave the talk, I totally understand, but I do want to get through some of these questions too. So Zado asks, if someone with epilepsy patient's diagnosis, major depressive disorder, what are the best antidepressant medications for high seizure threshold? And 2 is, could you explain non-pharmacologic treatment of epilepsy related to diet? So in terms of antidepressant treatment for epilepsy, like I said, a lot of times with depression and epilepsy, one of the best treatments is going to be managing the seizures. So making sure you have good anti-seizure medications to manage the seizures can help with the depression as well. If that doesn't work, there are medications that you want to avoid in people with epilepsy. The main one would be a medication called Wellbutrin or bupropion. Because that can lower the seizure threshold, like you mentioned. All other antidepressant medications, so the first line would be things like what we call SSRIs, or selective serotonin reuptake inhibitors. That would be things like sertraline or fluoxetine. Those are going to be good options to take in conjunction with epilepsy medications. One important thing to talk to your doctor about, though, is that a lot of times epilepsy medications have a lot of interactions with other drugs where they'll change the levels of other drugs that you're taking. And so it's important to talk to your doctor about taking 2 medications that interact okay with each other. And then the second question related to treatment of epilepsy related to diet. I think I might have to defer that one. That's probably a better question for one of the neurologists. I'm not quite as familiar with the research on epilepsy and diet, but something I'll be looking into for sure. Managing anxiety comorbid with epilepsy. So like I said, the main thing is going to be therapy. Specific types of therapy that can be helpful for anxiety is called cognitive behavioral therapy. And then medications can also be helpful. Actually, some of the medications that I mentioned before for depression, fluoxetine, sertraline, escitalopram, those can all be helpful for anxiety as well. They're actually great medications for anxiety too. And then again, some of those, if access to therapy or access to medications in the moment is difficult, and with these medications, a lot of times they take a long time to work. They take at least 4 to 6 weeks to work and have the full benefit. In the moment, though, if you're having an anxiety attack, using some of those grounding techniques that we talked about can be helpful. And then Senite asked, does having a child with autism and epilepsy create psychiatric disorders for family members? Absolutely. Like mental health of caregivers can definitely be affected when they're caring for someone with autism and epilepsy, or with any disorder that has a lot of like high needs. That can definitely come up. So making sure to support, caregivers that is going to be really important too. And getting treatment for caregivers too, if they need it, is going to be important. Um, and in terms of epilepsy, like cures for epilepsy, someone asked about that. Um, from my knowledge, so epilepsy can be caused by a lot of different things. So this is a little bit of a complex question, but there are medications that can manage it and minimize seizures over the long term, and procedures also, like surgeries and things like that, that can help minimize seizures long term. So it's more of a condition that gets managed rather than something that gets treated. And then Anat asked, how can we advise a person living with epilepsy to care for their mental health and well-being? So I think this can be approached multiple different ways, but really trying to get a sense of how the person feels that they're doing and where do they feel like things are not going well for them, and really highlighting that and helping them acknowledge that there are ways to help with the things that they're struggling with. It's not something that they have to suffer through. It's something that has their treatment options available, and it can help to try some of those treatment options. So starting from that standpoint of like, what do you feel like is going wrong and how can we help, I think would be a good place to start. And then Dr. Salim asked, aggression could be caused by many factors in epilepsy, but could you tell us a major cause of aggression in epilepsy? Because in my experience, it's most encountered behavioral challenge among people with epilepsy. Yeah, and you're correct. There's a lot of different reasons. I think the biggest things that I've seen are one, like structural changes in the brain can lead to an increased likelihood of having aggressive behaviors um, because of the seizures. Sometimes when folks are experiencing things like delirium after a seizure, that can also lead to some aggressive behaviors in that confused state. Sometimes certain medication side effects can be like increased irritability or aggressive behaviors. So there are epilepsy medications, seizure medications that have that side effect. But there are also seizure medications that don't. So again, this is not me trying to say like don't take your seizure medications, but there are additional options out there if you're on like a medication called Keppra, for example, and it's leading to a little bit more irritability and aggression. Um, so, and then the other thing that I think is not related to a psychiatric disorder, but just inability to communicate unmet needs. So I think the kind of core cause of aggression a lot of times is going to be like not being able to communicate a need that you have, and then not having that need met. Oh, and someone answered this question as well in a little bit more detail. It looks like aggression in epilepsy usually happens because seizures affect brain areas that control emotions, especially the temporal and frontal lobes. It can also be triggered by confusion after a seizure, medication side effects, or stress from living with the condition. Yeah. Um, and then Hewitt asked, after a patient has not had any seizure attack for the past 2 years and it's controlled after a normal EEG, how can we taper medication and how to taper it? That is going to be a question to discuss with a neurologist because different medications are tapered in different ways. Actually, are there any neurologists on right now who can comment on that question? I'm curious if anyone, if not, that's okay. That might, sorry, go ahead. Okay. I think that could be a good topic for another talk, though. It's an interesting topic. Um, we have epilepsy comorbid with diabetes and hypertension. Why? So again, a lot of different reasons why that could be the case. It could be related to your family history. Maybe like it is something that had already run in the family. And it's not typically something where like side effects of medication of seizure medications would lead to diabetes and hypertension. um, it can happen occasionally but not as much as other like psychiatric medications that I'm thinking of. um, but yeah, I mean we do know that there's an increased risk there for sure. I don't quite have as much specific information about why that comorbidity exists with diabetes and hypertension. Nowadays, neurological disorders are increasing in our country. What would be the cause? And this one was answered as well. It does feel like neurological problems are becoming more common. Um, People under more stress, not living the healthiest lifestyles, pollution doesn't help either. And then doctors are getting better at spotting these conditions. Is that's one of the first things that came to my mind when I saw this question, is that um, that these disorders are being talked about more and people are noticing and diagnosing them more because of that. Can you suggest materials or anything which can help for intellectually disabled children? I'll send a list of resources to Anat after this talk, and she can distribute it out. Let's see here. One more question. My cousin was recently diagnosed with epilepsy and sometimes becomes unresponsive, dizzy, and forgetful. As you said, it would happen right after epilepsy, but tends to last for quite a while before she returns to normal on a good day. She also has other health complications, and her epilepsy is still very new. Since she's too young for dementia, how can we tell if these symptoms are more likely related to seizure activity, medical side effects, or another underlying issue, and what kinds of early interventions and cognitive supports are most helpful to prevent long-term impairment? That is a great question. I think so. With these, what we call like post-ictal states right after a seizure, like I said, they last, the duration of them is really variable. It can be a few hours, it can sometimes be up to a day, maybe more than that. I think the fact that your cousin is, kind of um, coming back to eventually after these episodes is reassuring, but there are other things that could be contributing, and it's important to be talking to a doctor about what other things can be going on, because they can do additional testing, lab testing, to make sure that there's not other things that are contributing to them feeling like this. In terms of preventing long-term impairment, I would say managing the seizures adequately is going to be the most important thing. Making sure that the seizure frequency is not is as low as it can be with medications is going to be important. Okay. Any other questions? Anything else that anyone was curious about? I really appreciate all these questions. This is really an interesting discussion. I'm glad I got to talk about it with you all. Thank you, everyone. It was wonderful talking to you about this. I really enjoyed it. I appreciate you all. Thanks.